Now, in the last segment, as we wrap up this conversation, I want to take advantage of the opportunity of the experts here to talk about another exciting development that was reported at ESMO this year, which is not in metastatic disease, but in early stage disease, stage 3 unresectable non-small cell lung cancer. These are patients who are treated with concurrent chemotherapy and radiation. We've seen that with such an approach, 5-year survival rates is in the order of about 20%. Not really much progress in near 15, 20 years. But now we learned that durvalumab, a PD-L1 inhibitor, was tested in that setting and has shown activity. Paper out in New England Journal this week. So Benjamin, let me ask you to describe that study to the audience, and then we'll get Giorgio and Marina to weigh in on how they view these data as applicable to their patients.
So the PACIFIC study is a very simple study. It's designed for locally advanced stage 3 non-small cell lung cancer patients. All received definitive chemorad, and they were randomized up to 42 days after the end of the chemorad between placebo or durvalumab for 1 year. The results are quite impressive because the PFS of the control arm is 5 months and it's 16 months in the durvalumab arm. When there were the press release, a lot of comments on the positivity of the PFS were that it's a curative setting, a curative intent, so what we want to see is more patients cured, so a benefit in terms of overall survival, and we don't have the OS data yet. But it's true that the magnitude of the benefit is so impressive that we all think that there will be some improvement in the OS, and there is a curve on the time to event or the time to death that also suggests that the OS curves should be good. Let's see the rate of crossover, I mean when the patient will recur in the control arm if patient receive immunotherapy, but it can be considered today as a new standard of care in this indication.
Giorgio?
I fully agree. I fully agree because for the last 20 years we didn't get so. The PACIFIC study is filling the gap in a segment of the treatment of non-small cell lung cancer that was totally empty for 20 years. Because even today, and I'm speaking to European colleagues, not every patient with locally advanced non-small cell lung cancer is treated universally with concurrent chemo and radiotherapy. If we go, for instance, to UK, there is still a significant proportion of patients who are treated with sequential chemo and radiotherapy. But independently from the type of approach, that is not a matter of discussion today, there was nothing. So at the end of chemo and radiotherapy, you was just adopting a wait-and-see policy until progression. That is true, I mean. And again, the scientific data are telling you that you are prolonging PFS, but that is coming with another notion that, at least for me, is becoming every day more important. I was mentioning already before, any type of maintenance is becoming on the board, not only for chemotherapy, that was just an initial approach. It's true that we are treating oncogene-addicted tumors up to progression, maintaining the treatment. We are trying to do the same in second line and also in front line metastatic non-small cell lung cancer with immunotherapy. That is another way to deliver maintenance therapy in an effective way because the PFS was significantly improved. And again, it's moving along the line of making, obviously, it's still a dream, but to step by step to make lung cancer a type of chronic disease. That is my simple take from the study.
A couple of things I found particularly important from the study, in addition to what's been discussed so far, is one, tolerability profile. We did not see any excessive toxicity. Concerns about pneumonitis were reassuringly not a problem here. And the second observation I thought which was interesting is the PD-L1 expression didn't seem to matter because Here is a different situation where you have given chemotherapy and radiation to the tumor. It's already inflamed, so the PD-L1 expression didn't seem to make a big impact on the tumor. What are your observations, Marina?
No,
What do you think?
I fully agree with all the panel, because this is really a practice-changing, a clear practice-changing study. I think that just to comment something differently is that this study considered only concomitant chemotherapy, and maybe we have to work also on the sequential chemoradiation, because it's not always the option for all the stage 3 unresectable, the concomitant from the beginning. So I think that at the academic level, maybe we can work to collect the data also for the other strategies on the maintenance with durvalumab.
So exciting development in stage 3 disease. Do you see anything in the horizon for patients with resected non-small cell lung cancer, stage 1, 2, 3A? I know there are a lot of adjuvant therapy trials with checkpoint inhibitors. Anything you see as what people should keep their eye out for?
Well, immunotherapy works in melanoma, in resected melanoma, so a lot of trials are ongoing with PD-1 or PD-L1 agent in the adjuvant setting. It's 1 year of treatment. Considering the positivity of the durvalumab that is also curative intent, it's really, well, we are really waiting for this data that could be practice changing. Let's not wait that forget that in these studies, patients still receive chemo. It's an additional treatment. So if they are eligible to chemo, they receive chemo, and then they're randomized between immunotherapy or placebo. Let's wait for the result. One concern that I have is that each time you are playing with the immune system, you can have bad surprise, but long-term bad surprise. So for all these trials that are in the curative setting, we should have very long follow-up, probably up to 10 years, to be sure that this modulation of the immune system did not impact either side effect or secondary cancer.